Chad, thank you so much for doing this. I know the Methods Mondays are a big ask for folk to put slides together, but it's so interesting to have a deep dive into the different methods behind the different research projects. So often we just hear a snapshot of the findings and don't really get into the looking under the hood of how their projects are done. For anyone who doesn't know, Chad's a physiotherapist by clinical training and epidemiology training in addition to that as well. He's been worked as a physiotherapist as well as an ICU analyst, and he currently works with Jordan Miller, who's on the call today, and supporting multiple different research projects under their broad impact team. And it's exciting because this is a two-part series for June. So Chad's going to be talking about the process evaluation of a pragmatic randomized control. So a, I got that wrong, not a
Mhm.
pragmatic.
Uh, Cluster trial.
Cluster trial, sorry.
Yeah, there we go.
Sorry, that's on the tip of my tongue. Apologies.
Yeah.
And Jordan's going to be presenting the results of the cluster trial at the end of June on Friday, June 26th. So really neat to have the two combos. We don't often hear about the process evaluation. So Chad, really excited to hear from you today. I'm going to pass it over to you. And just also say that on this Thursday, if you haven't heard, we're also having a policy talk. The two Chris Booth and Chris Simpson will be presenting on a clinical trial looking at exercise and cancer. And Chris Simpson will be talking and will be asking questions from a policy perspective. So I will stop talking, Chad, and hand the floor over to you. Thank you for being here
All
today.
right. Thank you. All right, let me start sharing my screen here and make sure that that's all ready. Um, um,
And while Chad gets this all going, I'm just going to say thank
sorry.
you everyone for being here over your lunch. And this is actually the last Methods Monday of the year. And so we've had some great ones. And just for people who may not have been able to get to them, they're all posted up on the HSPRI YouTube channel. So for instance, Nora Faya did one on methods on outcome measures. Anna Johnson did a Methods Monday on economic evaluation. So there's a whole bunch of really exciting talks that are they're posted as well. Chad? Officially over to you.
Okay. All right. I'm having some trouble here. It's showing up on. Do you see it? Do you see
Yeah,
the
it looks great.
presentation?
Yeah.
Yeah, it's not allowing me to scroll forward, which is kind of interesting. Huh.
Sometimes it takes a little bit of like multiple clickings on your space bar, I find.
Hmm. Let's see. There we go. Okay. I think I've got it now. All right. Excellent. So everyone can see it, right?
Yes.
Yes. Okay. Great. Uh, well, thanks everyone for coming. I'm really actually quite excited to talk to you all about this today. So, Catherine, thanks for the great introduction. And yeah, like you alluded to, I'm going to be talking about something called cluster randomized controlled trials. So this is a pragmatic trial design that we can use for health services research, and hopefully you can become familiar with this study design. So just real quick, just to give a quick overview as to what we're going to be talking about today. So I want to introduce the concept of cluster trials for those of you that aren't familiar with it. And then I really want to talk about some of the reasons why you might choose a cluster trial design and some of the challenges with a cluster trial design that might actually lead you to choose a different trial design. That'll be kind of the first half of the presentation. And then the second half, I really want to present our two cluster trials that we have ongoing right now that we're just kind of wrapping up and kind of use those as a bit of a practical example to discuss some of the reasons why you would choose it and some of the challenges that we encountered as well. Okay, so we're probably all familiar with a randomized control trial. So in a randomized control trial, what we do is we take eligible participants, individual participants, and we randomize them to either an intervention or control group. The purpose of this is to make sure that we balance baseline characteristics based on sort of known and unknown factors between, say, two groups, so that we're comparing like groups to one another. So this is sort of one of the beauties of a randomization process. A little bit different in a cluster trial. So instead of randomizing individuals, what we do is we randomize clusters. So clusters can be things like schools, They can be hospitals, they can be primary care clinics, they can be even entire communities or even families. So what we do is we randomize the clusters into the intervention or control group instead of the individuals, and all of the individuals within those clusters get assigned to that group as well. So if clinic A gets assigned to the intervention group, all of the patients that attend that clinic will be part of the intervention group. There's a few different sort of definitions or classifications of cluster trials, and this has to do with sort of the target individual or the target intervention. So we have individual clusters. So this is what I was sort of alluding to. So we might have something like a clinic being randomized to the intervention or the control, but the target is the individual patients. So the patients still have to enroll, and we're going to be testing, say, an intervention on the patients, and the outcomes will measure at the patient level as well. It could happen at the professional level in addition. So something like a trial aiming to change the prescribing behavior amongst family physicians for antibiotic prescriptions and seeing if some type of intervention can change the way they make recommendations for antibiotics. So the intervention targets the healthcare professionals within the clusters, and also the outcomes will be measured at the level of the physician to see, for example, if they change their patterns or their behaviors in terms of prescriptions. We can have something like an external cluster where the there could be someone or something external to the cluster that's providing the intervention, for example. So it could be an entire town or a community that's exposed to a mass media anti-smoking campaign or something like that. So the media might be external to the community. Maybe it's provided by some organization. Maybe it's provided by the province. And then there's cluster. So the intervention is delivered at the cluster level and the outcomes are measured at the cluster level. So think something like a school-based obesity prevention trial or something like that, where entire schools, so the clusters, are randomized to either implement a new healthy food policy or increase physical activity program. So that's the intervention, or continue just as normal. So there's the delivery at the unit of the school. And then we're also going to be assessing the outcomes at the level of the school as well. So the intervention and the outcomes are cluster level. So why would we choose a cluster trial design? So one of the main reasons that is that we would like to use a cluster trial design if we're testing something like a complex intervention. So something like a model of care. So a model of care is a pretty good example of a type of intervention that we might want to test that doesn't have like a clear ingredient or clear thing that we actually want to be testing. So I think something like a diabetes management program that's being introduced into a primary care center. So part of that intervention could include adding a dietitian to the team, having education pieces, exercise pieces, interprofessional care. So we might not know exactly what's leading to the outcomes. We're testing a whole bunch of things at once, but not necessarily one thing, like, say, a placebo drug compared to an intervention drug. So we want to test these complex interventions, and we're going to see an example of this in our studies, in the studies that I'm going to present that we ran as well. The interventions themselves could be at the cluster level. So think something like where an intervention exposes all of the individuals within a cluster, and it can't necessarily be delivered to the individual. So again, let's go back to that mass media example of the anti-smoking. Say there's ads around town with anti-smoking campaign. You can't pick and choose who sees those posters. So everyone in the cluster is going to be exposed to the intervention, and so it doesn't even make it's not only not feasible, but it doesn't really make sense to do sort of an individually randomized trial. So you're going to actually need to have a cluster intervention. Something like training physicians as well might need to be delivered at the cluster level. So imagine you had to train a physician on a new cognitive behavioral therapy technique, for example, that they're going to be delivering as the intervention to their patients. They can't deliver the treatment to the control group either because they've learned new techniques with the new CBT program, and there could be sort of spillover effect, some learning on their part, and they wouldn't be an appropriate individual to deliver the care to the control group. So there might be, the cluster could actually, be, in that case, be the physicians delivering the care. There could be cluster level effects as well that we want to measure instead of individual effects. I was thinking of some examples for this, but something like a vaccine campaign. So we're all familiar with some type of vaccine study where we're looking at, does this vaccine prevent infection? But we might want to know, does providing free vaccines to a community result in that entire community eventually achieving herd immunity? So if we were to randomly give the vaccine to 50% of the people in the community, we would never know the true effect of having sort of collective immunity. So that's something that would actually need to be tested at the cluster level rather than the individual level. Contamination is something that I'm not going to talk too much about it here because I'm going to get in a little bit more detail on this in later on when it applies to our study. But basically, contamination of the treatment arms happens when there's spillover from the intervention into the control. As an example, imagine that a hospital program is introducing a new hand washing technique. So if it was an individually randomized trial, half of the target staff, let's say half of the nurses were exposed to the intervention, and then their colleagues that are in the control arms start to see that the new technique that they're using, or they ask questions, or they can actually sort of inadvertently learn some of the intervention techniques. It would start to dilute the intervention effect. So we wouldn't be able to actually be confident of the treatment effect in this example. Another example would be something like a workplace intervention that is focusing on employee well-being. Maybe there's exercise classes offered at lunch. You can imagine that those in the intervention group are going to be sort of exercising, having free classes at lunch. Those in the control group are going to see them exercising, know that they're not receiving the intervention, and that could actually bias some of the results at the end of the day as well. There could be logistical reasons that we might want to run a cluster trial. We might need to leverage all of the administrative staff, for example, within a study. We might need to use the expertise of the administrative staff because they might need to know the allocation of the study participants that are attending the clinic, for example. Some participants as well are just sort of naturally organized into clusters, so like families or classrooms, those kinds of things. So it might actually just make logistical sense to run a cluster trial, or something that needs to be tested within a community. There's a logistical piece to that as well, that if it's being tested at the level of the community, there might not be enough research personnel to travel to all communities. So if we have a cluster trial and we're introducing um, new research personnel, they would only have to travel to half of the geographical sites rather than all of them if it was a cluster trial. So it might be a bit of a logistical and in turn a bit of a cost saving there as well. So that does lead into the cost part. So that it could be that you actually need to hire less individuals if it's a cluster trial compared to an individually randomized trial, depending on the intervention. There are some instances where adherence could be improved in a cluster trial. So imagine you were running an intervention in a community health center that was trying to get healthcare providers to make referrals to the community more often for their patients, for example. If the staff involved in the study see their colleagues making more referrals to the community, they see the referral forms laying around the clinic, and they have chatter around the clinic and at lunchtime, it might actually make it more likely that they'll adhere to the protocol. So there might be some adherence reasons as to why we might want to run a cluster trial. So those are all the reasons well, there's lots of other reasons, but those are some reasons why you might want to choose a cluster trial. But generally, the idea though is that an individually randomized trial is actually preferred over a cluster randomized trial, unless you do have strong reason for needing to have that type of design. And so I'm just going to give you, so that means we're going to jump into the next bit here of talking about some of the challenges that you would expect to face in a cluster trial. So one of the issues is that we have dependent observations. So what I mean by that is imagine we have a bunch of individuals in a primary care clinic. It might be reasonable to believe that the individuals within the clinic are more similar to one another than individuals within another clinic are to one another. So, or for example, patients in one clinic might be more similar to one another than they would be had you selected two random people off the street. So, a primary care clinic that is situated in a rural community might be different than, might have patients that are more similar to one another had you selected a clinic that was in a large urban area. So, there might be things like socioeconomic status, income, even just like the occupation that those patients are likely to have that could be related to the outcome of interest. And there could be unmeasurable factors that we actually can't control for. So something, not to get too much into math here, but something that you'll see in the literature is something called an intra-cluster correlation coefficient, ICC. So you might have seen this before. But what this really is it's a measure of how similar individuals are within the same cluster compared to other clusters. Or more specifically, it's actually the proportional of total variance in an outcome that's attributable to differences between clusters. So if we had an ICC of 1, that would mean all individuals within the cluster are identical in terms of the outcome. If we had an ICC of 0, that means that they're completely independent and they're not related to one another. And I'm going to show you how that might have an impact here on your study, in particular the study design. So in the literature, you might see something called the design effect. So the design effect is this factor by which the required sample size that we have for a trial might need to be inflated just simply because of similarities between individuals within a cluster. So in cluster trials, the design effect, in fact, reflects this loss of statistical efficiency caused by correlations among individuals within the same cluster. So I gave a bit of an example. This is just a very basic sample size calculation. There's lots of different calculations out there using different types of correlation matrices and those kinds of things. But this I thought this could sort of illustrate what might happen to your study. So let's imagine a situation where we've done a sample size calculation for an individually randomized control trial, and we decided that we needed 300 subjects to achieve a power of 80% to find a difference in our outcomes. And we know that we have access to 20 different clusters, all of we'll say roughly equal size for argument's sake. So scenario one, the participants in the clinics are not very similar to one another. So only 1% or 0.01 or 1% of the total variance can be explained by between cluster differences. That would inflate the sample size by about 19%. And so we would see that sample size go from 300 to 357. Let's take another scenario where we have clinics where the patients are highly similar to one another. You're probably not going to see often an ICC of zero point 0.2. You might see it, zero point 0.1 or 0.15 even. But I think this illustrates what can happen. So if the participants or the patients within the clinic are very similar to one another in this example, it increased it by almost fivefold. So you go from needing 300 subjects to 1,440 subjects across those 20 clusters. So it has a pretty profound impact. I thought it was worth talking about actually some of the practical implications of this. And this does tie into, of course, still some of the challenges when you're thinking about designing a study like this. A lot of the times when you're doing your sample size calculation and determining feasibility of your study, you might actually have a fixed number of clusters available to you. So imagine you're in a situation where you need to cluster by hospital and you only have, say, 10 hospitals available to you within a reasonable distance of where you're conducting the study. A good approach would be to fix that cluster size, calculate the number of individuals you would need within each cluster to achieve your power, and then from there you could determine whether or not your study is indeed feasible. The other situation would be if you have a flexible number of clusters. So I just wanted to point out here that there is diminishing returns when you're adding individual. This isn't necessarily intuitive. So um, in an individually randomized trial, we think, okay, we can add individuals to increase the power of our study and make sure that we find differences where they truly exist. But in a cluster trial, there's pretty significant diminishing returns just by adding individuals. So if you have, because remember the unit of randomization and the unit of analysis really is the cluster. So if we get to a point where we have quite a few individuals within each cluster, we could add, you know, 50, 100 extra individuals to each cluster. So recruit 100 more patients from a hospital, and it's not really going to do much to your power. What you really need to do is add clusters to your power. So if power is your concern and you do have access to more clusters, perhaps you're running a study in the schools and you have access to between 20 and 50 schools. If you want to increase power, it's adding clusters that's going to significantly improve your situation if you're worried about being underpowered. And just to give you an example, in our power calculation for the study that I'm just about to talk to you about, if we had 20 clusters, if we held everything else constant, if we lost just one cluster, we would have lost somewhere between 5 and 8% power. So that just kind of gives you a rough idea as to how much how important it is to keep those clusters. Luckily, it used to be rather challenging actually to run some of these sample sizes. So I actually provided an online application link here for you in the slides, which you'll have available to you after. It's actually pretty easy now to make a sample size calculation for these types of trials. These apps have been well developed. It might be a bit of a challenge to find the appropriate correlation numbers to put in there, but that's just a matter of looking through the research and seeing what's reasonable. There are some statistical implications. Not everyone here, I think, is going to need to be aware of these. You might be passing the analysis off to someone else, but I do think it's worth sort of knowing that some of these challenges exist. So because we're adding this clustering effect in our models, there's clustering at the level of the clinics, but there also could be clustering at the level of the individual, meaning if we take repeated measures of someone over time, that individual represents a cluster as well. This is all to say that some of these models become a bit more complex. And when we add complexity to the models, sometimes that adds some challenge in that some of the models don't converge. It's just that they just simply won't run for a variety of reasons that we could probably chat about after. Um, but it just does add that complexity, and it's just being aware of sort of writing out your methods in a protocol beforehand. It might include, we'll have to select something like a covariance structure. So how we're going to model these similarities between clusters or within individuals. If you have a small number of clusters, so anything really 20 and less approximately is considered small, you might have to do some small sample corrections to your models in order to avoid things like type 1 errors or saying that there's a difference when there truly isn't. A lot of the time, depending on the regressions that you're running, there are some well-established ways to do this. But there are models where it's not as established as you might think, and you might have to be digging through some of the literature to find some ways, but to do the small sample correction. But it's really important that you do it so that you don't make that error. Missing data is not unique to cluster trials, that's for sure. But I thought I'd bring it up here because a lot of these cluster trials, including ours, uh, are longitudinal nature, for example. So collecting data, repeated measures over time, and you're going to have to explore you will, in fact, have missing data for sure. And depending on how much missing data you have, you're going to have to figure out whether or not that missing data could have led to bias. So you just have to have a plan in place to make sure that you know that you know what those missing data mechanisms are and how to deal with them. Cluster trials do introduce an increased risk of baseline imbalances. Again, the unit of randomization is the cluster, not the individual. So if we're randomizing 200 patients to the control or the intervention, it's a pretty good chance that our baseline characteristics are balanced. Now, when we're randomizing clusters, Suddenly, in our example, let's say we randomized 20 sites to either control or intervention. That means you're only randomizing 10 to the control, 10 to the intervention. If we had only two rural clinics, for example, in this example, if both of them are randomized to say the intervention, and there's reason to believe that rural clinics have patients that might respond differently to the treatment, then that could lead to bias. So it does increase the risk. We're going to talk about the strategy that we use to try to mitigate this risk, but just know that it exists, especially when there is heterogeneity between the clinics. So if they differ markedly across sort of factors that could influence the outcomes, you're going to have a plan in place in order to try to mitigate these baseline differences. Selection bias is certainly a big issue in cluster trials. There's lots of sources of selection bias, but a few that I'm going to talk about are the idea of blinding. So we typically randomize clusters to a control or intervention before individuals give consent. So it could actually be that it's quite hard to mask participants to the allocation of the cluster before they give consent. So patients might be attending a clinic where that diabetes management program is being offered, and they just know simply because either they've chatted with other people or they see the newly added dietitian to the team in the clinic. They might know that actually that clinic is indeed in the intervention arm, and that could lead to bias if you're only getting people enrolling in the study simply because they want access to the intervention. And then the control group, only people that are okay being in the control arm. So we really want to make sure that there isn't differences between the participants enrolling. The recruitment team or even like the staff working at these clinics, they can't be blinded. So the entire research team knows which clinics are in which arm. And so it makes it really important that when you're inviting participants to the study that you do it in the same way between arms. And that can actually lead as well to a change of process in how people are being enrolled in the intervention versus the control arm. Again, if the administrative staff, for example, knows that that there's this diabetes management program being run, they might actually be more likely to offer it to people that they think would benefit from it. Or if, in our case, we introduced a physiotherapist working in primary care, it could be that their primary care provider might be more likely to suggest they enroll in the study because they know that they're going to get access to a physiotherapist. So all of these things could lead to differences in patient characteristics that could be measurable or not measurable. So we do have to be really careful about this selection bias. Not only can it lead to these differences that we can't measure, it can actually lead to an imbalance in participant numbers between the intervention and control sites, and we really want to try to avoid that differential recruitment. There are ethical considerations as well for cluster trials. So the first two are kind of related to one another. There could be this hierarchical structure of the trial. So imagine that a hospital enrolls in a cluster trial, and the individuals making the decision to enroll are higher up. So let's say the CEO of the hospital agrees to participate in the study. That could force all of the individuals, all of the staff, to participate in something that they didn't truly give consent to. It could add extra work that might be passed on to the nursing staff, or take for example like a workplace productivity intervention where they're trying to test out like a new workplace software. So it's a company-wide decision to enroll in the study. All of the computers would have to be updated with new software, and the employees wouldn't have any choice uh, but to use that software. Depending on the data collected, of course, from them, there may or may not be consent requirements, and this is just going to be study dependent and something that you might have to discuss with your ethics board. There's also this idea that, like I alluded to, that the randomization happens before we enroll individuals. So, in fact, a lot of the time, there isn't actually truly a random chance of people being in the control or the intervention because it's decided beforehand. which site they're or which intervention they're going to be in should they decide to enroll. So again, this is something unique to each study and might just have to be considered at the level of ethics. Okay, so we just talked about some of the reasons that you might want to run a cluster trial and some of the challenges. Let's use practical example with two studies that we recently conducted and are in the process of wrapping up and getting published. So we ran two studies in primary care. So we introduced physiotherapists into primary care for the management of low back, hip, and knee pain. So physiotherapists were available as the first point of contact for back, hip, or knee pain. And it was randomized. We randomized the clusters. So there'll be a slide on this in a second, but we had 20 clusters. 10 had a physiotherapist on board, and 10 carried on with normal physician or nurse practitioner led care. The objectives of the study, not to get into too much detail of this, but it's more about the process. But the main objective was to estimate the effectiveness of this PT-led model of care on functioning or disability as the primary outcome compared to usual physician or nurse practitioner-led care. And we also looked secondarily at other secondary outcomes as well, but also some of the health system and societal impacts through healthcare utilization, cost effectiveness, again, evaluated over a 1 year period. Just to give you a bit of a visual representation of the study design as well. So we did a 2-arm parallel longitudinal cluster randomized trial. I know that's a lot, with baseline measures. So we measured everyone at baseline, and then we took repeat measures at, say, 3 months, 6 months, 9 months, 12 months. And then you can see shaded in sort of the dark blue, sort of half of the clusters were randomized to the intervention and the other half maintained usual care. And so that's how we followed individuals over time. And at baseline, everyone is technically unexposed to the physiotherapy model of care. So that's why that's still shaded in light. So we got a measurement before they were exposed to being able to see a physiotherapist, and then I measured what happened over time. So just to give a bit more detail about it. So like I said, we introduced PTs to primary care sites over 12 months. There were two separate studies. The back pain study was in Ontario and British Columbia, and the hip knee pain study was just in Ontario. And we had measurements across various time points, and both our primary outcomes for both of those studies were disability or function related, and they were on a continuous scale, which we'll touch briefly on when we talk about a little bit about modeling. We had quite a few different secondary outcomes, including societal impacts, that just kind of speaks to the complexity of the intervention that we are trying to test and all of the different outcomes we were interested in exploring. So why did we choose this design? So I gave all those challenges, but why did we land on wanting to do a cluster trial? So, like I said, this is a complex intervention, and we were testing a model of care. So there are guidelines where PTs can provide care in a primary care setting, but there isn't really a single ingredient that we were wanting to evaluate. So the PTs, it was kind of up to their discretion to provide the care, but they may have been able to have an impact on patient health outcomes in various and complicated ways. Could be that they were more likely to provide exercise and activity. They could have been more likely to provide collaborative care, or they might have been able to see patients faster simply because they were able to help offload physician or nurse practitioner workloads. So there could have been a bunch of different ways that this operated. And so, testing this model of care is perfect for this cluster design. The intervention is applied at the level of the cluster. So everyone within the cluster was exposed to having the PT on site. And anyone enrolling in the study, would have the opportunity of seeing the PT if they were enrolled in a site that was in the intervention arm. There's some logistics as well so if this were an individually randomized trial, we would have needed to have hired a PT to be at every single site. And while they were at the sites, they would have only been seeing half the participants in the trial. So if we individually randomized each site, individual at each site, then yeah, the PT would only be able to treat half of them. And so there's a hiring thing that we would personnel component that we would need to take into account. And that's not even thinking about sort of the geographical spread of some of the clinics getting PTs to different sites and that kind of thing. So the HR demands would grow. There's increased cost for training. So suddenly we have to train twice as many physiotherapists. So that could have been higher as well. Also increases the risk of losing someone during during the study. We got pretty lucky. One PT did leave the study during the window, but we were able to quickly find someone to replace them. But obviously, if we had more uh, PTs on the team, that could have increased the risk of something like that happening. I thought this deserved kind of its own slide. So this idea of contamination, which was one of the main reasons that we decided to go with the cluster trial. So there's different levels of contamination that I wanted to sort of point out. So provider level, clinic, and patient participant level. So at the provider level, the physicians may have changed their approach simply by having a PT around if it was an individually randomized trial. So by having the PT on site, they might have been more likely to provide exercises to individuals in the control arm, or they might have been more likely to refer to physiotherapy or chiropractic in the community. And the other providers could, learn from having just a new healthcare provider on the team, and they might, in fact, have applied some of those learnings to the individuals in the control arm. So we wouldn't have been able to really test sort of how that model of care would have operated on its own. There could have been, just having another provider on the team could increase communication between healthcare providers, and there could have been intervention mixing as well. At the clinic level, we can imagine a situation where something like wait times is altered just by having a new healthcare provider on the team. So by adding a PT to a clinic, it could have artificially reduced the wait times for individuals in the control arm. So if the physiotherapist is there and they're offloading the physician NPs or other providers, then it could have freed up time for everyone to see their physician. And again, that wouldn't have given us a true estimate as to the impact of that model of care. There could be contamination happening at the level of the medical office assistant as well, the MOA. So it could be that they're overburdened and having to keep track of who is in the intervention and the control arm, and they might inadvertently book patients in with the PT who are in the control. So there could be something happening there at an administrative level as well. And then, of course, with patients. So it could change patients' behaviors. So they could see that the PT is in the clinic. They might be more likely to seek PT in the community just because they see one at the site. And there's a shared population, so patients might talk to each other. They might two people might be enrolled, one in the control, one in the intervention. The one in the control arm might adopt some of the exercises and the advice shared to their friend in the intervention. And so there could be that spillover of the learned experience, or they could just feel like simply that they're missing out because they see the PT treating other people, and that could bias the results on the surveys. So here's some of the challenges that we encountered. This is not exhaustive, but I thought some of the main ones that I thought worth pointing out, and how we dealt with it. So we talked about that risk of baseline imbalances being an issue in cluster trials. So we only had 20 clusters, and there's that risk of having imbalance because we had some rural clinics and we had variation in clinic size. So we used something called covariate constrained randomization. So what we did is we were able to identify a few factors that we knew we could measure and that we knew could be related to patient health outcomes. And so what we did is we did the randomization and balanced on those to make sure that we had an equal number of rural clinics in the control and intervention, and that there was sort of a roughly balanced, a rough balance in, say, clinic size, for example, just in case like larger clinics have a different patient population than smaller clinics. We were able to deal with that statistical precision of small sample correction quite easily using something called the Kenward-Roger small sample correction. So ours were continuous outcomes. This is a pretty well-established way to adjust for this. But again, you might need to seek other methods if you're using different models. There's that idea of some of the model complexity and non-convergence of some of your outcomes. So what we really wanted to make sure that we did is that we pre-specified our model building strategy in our published protocol. So there was concern that some of the models wouldn't run, and so we wanted to outline very specifically how we would try to deal with this. So we listed which covariates in our model we would remove and in what order, and we were very clear about how we would select that covariance structure. So how we're going to model the similarities between individuals within clusters. So that transparency is there to try to avoid any analytical biases. There's that selection bias that I talked about. So we had that risk of patients being unblinded. So, the physiotherapist was available on site, so they might have in fact known that the clinic they were attending was in the intervention. So we had to avoid revealing the allocation till after consent. So our research assistants were excellent at presenting the study in the same way to the control and the intervention group, and not letting them know that the site was enrolled in which arm until after they agreed. If they did indicate that they knew which arm the clinic was allocated to, or they said that they would not be willing to participate if they didn't see the physiotherapist, then unfortunately we had to tell them that they weren't eligible for participation. The clinic staff was not blinded, of course. That's not possible. Everyone had to know that the physiotherapist was coming into work, so we had to have standardized scripts to connect potential participants with research staff, and we really made sure that the recruitment actually lived with us instead of with the staff at the clinics, because our research assistants, like I said, were excellent at being able to describe the study and making sure that they explained it the same way to everyone. We did start to notice an imbalance in study arms actually right away, and that the intervention arms were recruiting people at a faster rate. And so what we had to do is get on that pretty quickly, actually, even after a few weeks, we could see this trend happening. So we wanted to provide we tried to mitigate this by providing regular reminders to healthcare providers and the team that the study is ongoing and that we need to invite all individuals with back, hip, and knee pain to the study. We tried to make the recruitment process as easy as possible for all staff. And the other strategy that we did is we did provide some on-site presence of research staff. So you can imagine the physiotherapist was available at the intervention sites, and just having them around would remind providers that the study is ongoing. And so we tried to sort of mimic this in the control arms just by having a research assistant available on site to help recruit. So hopefully, and it did help quite a bit, just having a research assistant available was the constant reminder that the study is still going and that we need to invite all consecutive patients to potentially enroll. Loss to follow-up. So this can happen at a few different levels. So a loss of a clinic would be like I mentioned in our power calculations, pretty impactful to the results. So as we were recruiting clinics to participate, we really made it clear to them that they could only agree to participate if they were okay being in the control arm. So obviously the clinics they seemed to be quite excited to have the potential of having a physiotherapist added to their team that was covered by our research team. But they had to be okay with the fact that there's a 50-50 chance that they would receive that extra healthcare provider to join their team. And so the randomization happened only after they agreed to participate, which is really important. We wanted to try to avoid participant withdrawal after the allocation was revealed as well at the individual level. So the patients, when we were inviting them, had to agree to be okay to be in the control arm if that was indeed the case. And if they weren't, then we weren't able to enroll them. We had missing data, of course, with incomplete surveys. So between the two studies, we had somewhere around 1,400 participants, and so that's a lot of surveys happening across a 1 year period. And so we really had to make sure we had a very standardized and very strict follow-up strategy in order to get everyone to complete the surveys. So multiple emails, phone calls, text messages. Sometimes these were individual. Some participants had very specific requirements that we just tried to make it as easy as possible for them to be able um, to complete the surveys. Again, no matter what you do, you're still going to have missing data, and we did, of course. So some time points are missing in entire surveys. The way that we dealt with that is in our published protocol, we had a sensitivity analysis laid out to discuss how we were going to explore any of these missing data mechanisms, and yeah, and just make sure that we followed that and use that to explore any sources of bias. Running a cluster trial is no small task. There's lots of other things that you need to consider when you're, say, putting in a grant for a cluster trial. There's things that take a lot more time than you might expect too. So, ours, we had 20 sites. That means 20 different data sharing agreements for each site. That means, getting contracts at Queens to have, individualized contracts for each site. Maybe lawyers on their end to help with the process. So that took quite a while, a few months even to get those in place before we launched. We needed EHR, so electronic medical record access, to extract some data. So we needed to have this lined up before we started that we needed access to either remote or on-site EHR access. That's something that had to be in place. There was pretty huge human resource requirements. So we needed to hire physiotherapists, research assistants, and all of the related contracts that come along with that. Be mindful as well that there's ongoing evaluation, and you need to be really adaptable, something like this. So, like I said, we were constantly monitoring recruitment numbers between arms, and we just had to be adaptable and be nimble in order to try and mitigate this imbalance in real time. Otherwise, you wait a few months and it's too late. And just keeping track of the process, make sure that the recruitment is going the same across all sites. So it does require a lot of surveillance along the way. Something that we hadn't really thought about until it happened a couple times is that we had new providers joining the team. So one of the sites added a physician, a small site added a physician to the team. So that required us to, contact that physician, train them on the recruitment process, and make sure that they're aware of the study. We've collected data through online surveys. So REDCap is what we used. You have survey technical challenges along the way that luckily here at Queens we have access to uh, some experts that can help us with this, but it is something that came up on a fairly regular basis that we had just had to troubleshoot. We had to be flexible with meeting with participants. So, some participants didn't want to do anything online, and we wanted to make sure there's a lot of people that get left behind if we're running a study where we can't offer, say, in-person visits simply because they don't want to use online surveys. So we had to be flexible, meeting with participants either at their homes or at the clinics, or giving them a phone call, doing the surveys over the phone. So we just had to come up with different strategies there. We made sure that we had made appropriate communication with clinical sites. So this included even what I have listed here, semi-regular updates, just letting them know how the study's going. We did site visits to maintain good rapport with our partners, and just, again, reminding them that the study is going on, having some visits, bringing coffee, saying hello. Felt that was a really, really important part of the study. And we also had ongoing engagement with the intervention team. So, we had our physiotherapists working at the sites on their own, and we wanted to get them together semi-regularly to discuss some challenges, some successes, share, some learnings from working in a primary care environment so that we could be, consistent across sites. So that's another small piece that you might need to keep in mind. And sorry, I went over time a little bit, but that is all. Uh, thank you for attending.
Thank you, Chad. That was remarkable. I mean, just was thinking I've made lots of notes just about the exquisite details and methodological rigor of the study. Really, truly impressive.
Thank
I have a few
you.
questions, and I don't want
Hmm.
to take up all of the time. I thought maybe what we'll do is if you don't mind stop sharing your screen, we can open it up for
Hmm.
some questions. And I just have a few if others don't. Sometimes I find people just
Hmm.
need to sort of process some of the information too. So
Yeah, sorry. I throw a lot out there, and
no,
hopefully a couple things stick.
no, it's excellent. I have a
Hmm.
few questions. Maybe I'll let
Hmm.
people think while I start. You know, because it's a complex intervention, it's so tricky. When you think of like an intervention being a model of care, and
Hmm.
physiotherapists obviously are providing guideline interventions, but as you said yourself, it could look slightly differently. What did you do in terms of monitoring like how the physiotherapists were working? Did you have, I don't, and if you did, I apologize, like fidelity, like, did you have fidelity checklists? Did you meet with them regularly? You talked about, when team members might have come and gone. How did you monitor the complexity of the intervention itself?
Yeah, it's a great question. So we did try to tackle that actually pretty early. So we had the physiotherapist do a fidelity
Mm,
piece early on, and we got them to each individually fill that out, and then we met with them individually to see which pieces they were doing well, which pieces they were struggling with, and tried to compare it across BTs. So that was a meeting with them individually, making sure that everyone was on the same page, but also meeting, like I mentioned, sort of having sort of regular touch points.
mm,
So, because it is complex and
mhm,
the care being delivered is going to be unique to the patient, it's going to be different. And so we just wanted to make sure that we got together to discuss how that care was being delivered. So we would have some meetings where we'd have particular topics to discuss around the intervention being provided. But we also had like a Teams channel, for example, where we
mm,
posted things like where we posted questions that would come up. We had a folder where we had like local community resources. So a
mm,
lot of our clinics were here in sort of the Kingston area, so we had a folder that all the PTs had access to for community resources that they could refer their patients to. And so just things like that to try to get
mm,
everyone on the same page. But I think like the important piece was to try to make sure everyone's on the same page. It's learning too. It's a new environment. Primary care is different than
mhm,
what physiotherapists are typically used to.
mhm, mhm. No, that's amazing. There's a few questions here.
Hmm.
And again, I have a whole laundry list, but I will talk to you another time. And I
Hmm.
think I know them, but just it's so interesting to hear you reflect on the complexity of this trial
Hmm.
and just reminding me how many data points you had over time too. So Adanam, I don't know, why don't you go off mute, Adanam, if you don't mind, or I can read if that's better.
No problem. So thank you so much, Chad. This is wonderful. I had the similar data analysis techniques that I followed before, but it was clustered only in terms of like location. But your data set has cluster in terms of clinics, and at the same time, there is a repeated nature of the data, which is another correlation point. So I think it's easy to miss this repeatedness or correlation in the analysis. I just wanted to know that what are some like common things that researchers miss while analyzing clustered and repeated nature data?
Yeah, it's a great question. Are you specifically pointing to the repeated part or the clinic clustered part, I suppose?
Yeah, so in the analysis, I think the ICC usually it's used for the clustered nature.
Hmm.
Yeah, and there's the repeated nature of the data as well.
Yeah. So I
So
think, oh,
yeah,
go ahead. Sorry.
that's the question.
Yeah, okay. Yeah, no, it's a really great question. I think we have actually stumbled across some studies that probably should have been clustered and weren't. I think that that's like something that somehow has slipped through peer review processes before. Um, but you're right. There's clustering at the clinic level and there's clustering at the individual level. So this study is actually considered three level. So it's repeated measures within individuals within clusters. And so I think what you really need to make sure, I sort of alluded to it a little bit with the model building piece, but it's really having a plan in place for how you're going to select those correlations. So what we did is we outlined that we're going to be using this information criteria, AIC, BIC. I'm not sure if you've heard of those before, but we said in our protocol that we're going to use those to select the best correlation um, matrix. And so we said how we're going to model it. That's from sort of the model building perspective. I think from the like a practical perspective, it's just really making sure you have a plan in place to mitigate missing data, especially when it's repeated measures. So every measure that you get at an individual at a particular time point is valuable, and just making sure you've got a plan and personnel in place to be able to collect this data and try to chase people down, when they're not filling it out, particularly if your time point of interest or at your time point of interest. Ours was at 12 months at the end of the study. And so we wanted to make sure that we got that last survey complete. So it's really just important to have a plan in place to make sure you're capturing all that data.
Yeah, thank you so much.
Mm.
Thanks very much, Chad. I'm just looking at the time. There's just a few minutes before one. I'm just thinking people probably want to transition to their next meeting. The exciting part about this study is that Jordan's following you too. So people can take a look at we'll have this on YouTube beforehand, Jordan's. So people can take a look and be ready and prepped for Jordan when you present. I'm just reminding myself that's on June 26th, I think that is. Um, yeah, June 26th on a Friday. So really looking forward to really compelling results. And I think people will be interested to see both sort of unpacking the methodology, deep methodology today and the results next week or at the end of the month. Thanks so much, Chad, and exciting to see yours, Jordan, coming up. I don't know if you want to say any plug before anyone goes.
No, just amazing job, Chad. You walked through the methods lovely, and yeah, either of us would be happy to have questions come up at the next one too, if they're relevant to the methods, even when we're presenting the results. So,
Yeah, excellent work, Chad. Really nicely done and so clearly presented. Have a great rest of the day,
so
everybody.
Thanks, everyone.